I'd like to introduce our first keynote speaker. Ron Emerson, RN BSN, is the Global Healthcare Lead at Zoom. He is a former member of the Board of Directors for the American Telemedicine Association and chair of the Industry Council. He has more than 20 years' experience in the healthcare industry, having worked on a number of telemedicine programs in 46 countries. He is recognized as a thought leader in telehealth, having developed a variety of innovative telehealth applications and consulted on telehealth deployments worldwide. He is also from Maine, where I am from, so it is a very exciting gathering of Mainers today. There's a whole two of us. So I'd like to bring Ron to the stage.
All right, thank you very much. I appreciate that, Ashley. And first of all, it's great to be here with everyone. And as we said, I know I'm on about 10 to 14 Zoom calls a day, and it's nice to actually shake hands and see people in person. So first of all, just a thank you to all of you who have done such a great job on working and to provide the internet and the access points that we need so we can utilize these technologies that are really helping a lot of people. So today I'm going to talk about what I've seen in the US in regards to telehealth and the expansion, and of course the impact that the pandemic's had on it, and then sort of what we see as next steps. All right, so I think the first thing is just a little bit of my background. I'm originally from the UP of Michigan, Upper Peninsula, moved to Maine when I was about 30, and Marine Corps, bachelor's degree in nursing, worked in the clinical setting, then I became a nurse. And I worked in the acute cardiopulmonary, and then I had this opportunity. I saw this ad in the paper. It's like, do you want to be a nurse coordinator? I was like, that sounds pretty cool, man. Like, okay, I've kind of like this in-hospital nurse stuff maybe isn't exactly where I want to be, the right fit for me. I'd rather do system change. So I became a nurse coordinator where I would go to rural parts of Maine, and I would actually teach other nurses how to utilize technology so that they could present patients to clinicians who were a long ways away, right? And I'm going to age myself here, but I was 30 at the time, and this is 24 years ago, so it's been quite a while. And the only place that you could actually have access like that was basically going to a medical facility, and a lot of it was over ISDN, right? We didn't actually have broadband. And in the home was just out of the question. We used to do remote patient monitoring. It was all on POTS lines on dial-up, and then you would do a video call with someone, because the cool thing about what you folks have done now is we can use like remote patient monitoring. We can monitor someone's, like they have let's say they have the congestive heart failure. We can monitor them, and you have 100 patients on this technology, and let's say 5 of them come back and their parameters are out of where you and the clinician set them, right? And then now, though, we can use video and high-level interactions to react to that data. Before, guess what I had to do? Hop in my car and drive like 2 hours in rural Maine, right? So we've come a long ways. But I think the real light came on for me was just just really understanding the correlation between quality of care and access to care. And guess what the #1 determinant is that people use to decide which primary care doctor they're going to use? What do you think it is? Access, right? 89% of people say access to care is their main driver. So it's just huge. Now, just a quick question. So before the pandemic, how many of you actually used a telemedicine visit? Let's just say telemedicine as like maybe getting on the phone with the provider and doing a video call. Did anyone use that before the pandemic? Okay, this gentleman here did, so a few of us, like 4. Okay, awesome. Okay, what percentage of people do you think actually used telemedicine before the pandemic that could? And we know this from private pay insurers, and we also know this from self-insured employers. So if they could, and it was paid for, what percent of people actually do you think used it? Any guesses? Less. That's great. You guys are pretty. It was less than 3%, but you're really close. Sometimes I get it's higher, but it was actually quite small, right? And then of course this thing called COVID came along, and so how was your network used, and what did Zoom see? So if you look at Zoom, in December of 2019, we had 10 million daily meeting participants. So every day, about 10 million people would get on Zoom. 3.5 months later, play the guess game again. Any guesses on how many people were using Zoom every day? 100 million? Higher? 200 higher. 300 million people a day. Yeah, so within 3.5 months, Zoom went from 10 million daily meeting participants to 300 million people using Zoom every single day. And we saw that same correlation in telehealth because we were less than 3% of people that actually used telehealth to see their doctor. But during COVID, McKinsey did a study that showed that during COVID, because we needed to stay away from the actual virus itself, that we had 50% of outpatient visits were actually being completed virtually during COVID, okay? Right now, at this point, it's between 8 and about 22% is what the data shows, okay? So we're still seeing large use of it in general, but it's not where it was, of course, and we're sort of seeing model shift a little bit on that as well. Now, the other thing I think that's important is we're all here to serve the patient, okay? So, and I'll just, for those of you that have used telehealth and maybe had a video visit, would you do it again? Okay, gentlemen, yes. Those of you that have done it, okay, you do it again. So Zoom did a study. We did it in 10 countries with almost 9,000 people, and it was through Qualtrics. And what we found is that in the U.S., that 62% of Americans that actually had received a video visit within 6 months said that they wanted a hybrid model of care. So when you look at healthcare and you look at telehealth, what we're finding is it's not just a digital first model. In some cases, it is digital first, but it's a hybrid model of care where the actual clinical situation is dictating the level of interaction with the healthcare system. So that's where things are going. So when you look at broadband and what we're doing, but the interesting thing is that there was a report by Forrester that the very first year, we the U.S. did about 425 million consults in the first year of COVID, outpatient consults. A lot of the large centers of excellence that Zoom works with, and Zoom is in 9 out of the 10 of them as their virtual care solution, they were up to 75 to 90% of their outpatient visits were being done virtually. And that's because a lot of the great work that you folks have done as far as putting things down, and then the regulatory. I know we have some folks here from the policymakers and government influences, and just the biggest thing. When I started telemedicine 20 years ago, we're all incentivized, right? All of us have incentivization. We're incentivized. We have our jobs. How are healthcare organizations incentivized? Financially, right? Just like everybody else. They have a bottom line they have to make. And the Public Health Emergency Act, for those of you that don't know this, for telehealth, is prior to telehealth, a patient had to be physically located like in a hospital, a critical care access hospital, a rural health facility. They had to be in a facility, and it had to be, this is for Medicare patients that are 65 years and older, and they had to be physically located in one of those facilities, and then they also had to be, care had to be provided by a specific provider. But when the Public Health Emergency Act came in, that was all waived. So a patient could be in their home and they could get reimbursement. That's all underneath the Public Health Emergency Act. So when the Public Health Emergency Act goes away, one of the fears is, and because we're still working on legislation to push this through, is that we can keep a lot of the reimbursement and a lot of the regulatory that we have now, because when that stops, that'll stop over. How many of you have parents that have actually used telehealth that are over 65? Anybody have? Okay, right? So that's what's at risk here. So our parents and folks that are, so any of you that have influence, like there's the Connect Care Act, which is a good one. It has a lot of bipartisan support. We all want to do the right thing. And what we're finding is the data's coming out that clinicians are liking it. And we're also finding out that there is comparison studies that are showing telemedicine visits, the diagnosis. So let's say Ashley is a psychiatrist and she sees me in person and she makes a diagnosis, right? And then Josh is a psychiatrist and he walks in and then he does it over video. So you guys, the diagnosis is exactly the same as if they both saw me in person. There's no variance. So we have a lot of data that's showing the strength of the technology and how it can be done. And then from a cost perspective, this is something we're working with Medicare. Right now, the government, CMS, they see it as sort of an added cost, right? There was a really interesting study done by University of Pittsburgh Medical Center, and they're a payer provider. So they're the insurance company, so they're the payer like Medicare is. They're a payer, and they provide the clinical services. They have the doctors, so they can track this data. And what they found for urgent care, so you just call, you have a sore throat, an earache, whatever it is, for urgent care, that they were able to save $128 per patient. Now, what's impressive about that is that they actually tracked it over a 3-month period. So it wasn't just like Josh had to be seen by a doctor today, and he did it over video, and then 3 days later, Josh ended up in urgent care or the emergency room, right? They tracked it for 3 months. It was a durable treatment, and what we found is that they were still able to save $128, so it was a solid treatment. Kaiser, who's one of the leaders in this space, right, with managed care, they actually predict that 70% of all urgent care visits can be done virtually, okay? So we are seeing the rise of digital-first healthcare. That was unprecedented, of course, because of COVID. The other thing that we're seeing, I think that is key, and it affects all of us, is just the rapid decentralization of healthcare. And what that means is just simply that things that you would traditionally had to go into your medical facility for, you no longer have to, that we realize the importance of reaching across the continuum of care, which is the patient's home, other facilities, and allowing people to get that highest level of care and access to what they traditionally would have had to go to a facility in a center for. Now, I think one of the key examples of that that I think just sticks out for me is who's heard of Hospital at Home? Anybody heard of Hospital at Home? No? Hospital at Home, it's a program that Medicare put on, CMS, Medicare put it on, and there's about 242 organizations, healthcare systems, that are actually certified to provide services that there would otherwise be provided in an inpatient hospitalization inside of the home, okay? Think of like post-surgical discharge, where it's a little more complicated. Think of like pneumonias and just less complex. You'd have a decrease in nosocomial infections, but this is being done today. As a global role, I meet with probably 5 or 6 different countries a week, and Australia is really taken off on this. So instead of getting discharged and being automatically the de facto as you're in the hospital, they set them up in their home. You can have IVs, you have a hospital bed. If you need oxygen, you have an O2 concentrator. And then, a lot of the organizations, some of them are actually using Zoom to connect in. To actually connect in and provide the communication with the calculation. But what's the biggest part of all of this is the shift we're seeing is that the de facto standard isn't that you just call your doctor and that you automatically have to go to your doctor. The standard is now you actually call your doctor, and then they look at the clinical need, and then they dictate what level of interaction you need to have based on that clinical need. And something else, and I know I only have 20 minutes, that's gonna stop with that, that's driving that is a shift away from just fee-for-service, right? Medicare has done a good job starting out with accountable care and value-based care. But I think what's big is we move more towards capitated rates. 40% of Americans are underneath alternative payment systems. So right now, clinicians are incentivized for the patient to come through the door and they see them if it's fee-for-service. And then they leave and there's no real value, there's no accountability there as much, right? But once we move, truly, we make that shift where it's more value-based care, it's gonna be about, hey, okay, Ashley, we're going to give you $1,000 a month to take care of Emerson and his family. Now you figure out how you're going to do that. That's on you. And with that $1,000, you got to make it work. So that's when telemedicine and other things come more into motion and actually have more impact. So just some thoughts. Zoom is actually I'm proud to say we're the market share leader in telehealth. We have about over 30% of the organizations and people use Zoom for patients to see their doctors. And just a huge thank you to all of you that are out there providing the network and doing all the hard work so we can reach people regardless of where they're located, because without what you folks do, honestly, our technology would just go nowhere, right? So thank you for having me today, and I hope this shed a little insight into what we're seeing. Thank you.